Now we're going to move on to haematology. So just have a think in your head, think, how happy am I with haematology? Am I confident that if it came up in an OSCE, I'd know what to do? That's probably the answer, isn't it? I definitely, when I did finals, I was like, oh, we've not really been taught haematology very well, or very much, so it was a bit frustrating. But I'm going to highlight to you the important things, okay? And I really like haematology. It's really interesting, and I'm hopefully going to break it down for you in a fairly simple manner, okay? Right, so you've read those now probably by now, but I just enjoy this. This made me laugh. So 2 blood cells met and fell in love, but alas, it was all in vain. So we're going to chat about all of that. Okay, haematology, not that hard, pretty simple. We've got one cell that's pluripotent at the top. Okay, this is just so that we can put it all into context. 2 coming down. I drew this, by the way, with a lymphoid cell on one, myeloid cell, stem cell on the other. Lymphoid does your lymph bits and bobs, so your B cells, your T cells, and your natural killer cells, so like all the antibodies in your lymph nodes and lymphatic system. And then myeloid, more bone marrow, does all your red blood cells, neutrophils, platelets, okay? So just have in your head the 2 streams, lymphoid, myeloid. And that should help you to be able to put all of this in context. Okay, say out loud to me, if you can, how am I expecting a person with a haematological disorder in an OSCE to present? Okay, I haven't made this interactive one because I kind of want you to say it rather than write it. I'll give you 2 seconds. Okay, so these are the ones that are annoying because they're really non-specific. So they're going to be tired. They're going to be bruising easily. That's probably too easy for them to give you. I reckon they're just going to be fatigued and malazed. Maybe they'll keep having infections, might have a bit of weight loss, loss of appetite. Those are more for the cancers. And obviously all the signs that they're not clotting, so easy bruising, epistaxis. And generalised lumps and bumps, so kind of the non-tender lymph nodes that are persistently there are a concern for us. Okay, so the history in haematological diseases, a normal history, but also just ask if you're thinking it might be something to do with haematology. Have you had a blood transfusion before? Do you have any family history of sickle cell disease or anything like that? Okay. So we're going to go straight into a case. I've done this one slightly differently. So Steve is a 75-year-old male who presents to your GP with worsening short of breath. He reports being very tired and has decreased stamina. Some blood tests have recently been taken, and I have not given those to you yet. I want you to look at this properly. Please take a short history, explain the diagnosis, and give a management plan. Okay, what can you get from this little extract? This is kind of what you get in your OSCEs. You can get a lot. So you've got age, you've got a presenting complaint, you've got the fact that he's tired and not able to do as much. And they've told you take a short history, explain a diagnosis, they want you to make a diagnosis, and give a management plan. So they want quite a lot here. So if we're thinking age, you've got like that 1 or 2 minutes between the bell. First of all, dump the station before. That doesn't matter. The next examiner doesn't know that you've totally screwed the last one up or that you were amazing and you can explain warfarin like no one else. So dump that. That doesn't matter. You're on to this one. You know they're old. They could have heart failure. They could have CVD. They could basically have any disease, but they're unlikely to have like pyloric stenosis because it's in a baby. So we've knocked out some differentials and added in some. They're tired. Tired people need investigating. Do they have hypothyroidism? Do they have a cancer? Are they tired because they're fighting an infection? Is their tiredness actually, does this guy not get out of bed because his mental health is so terrible and he's so depressed? So you're kind of thinking about differentials. Shortness of breath. Don't just think about respiratory, okay? There's loads of things, cardiac, respiratory, GI, haematology, endocrine, could be anything. Oh, wait, there we go. And just on short history. Short doesn't mean incomplete. I hate the phrase take a short history. They still want you to basically get everything. There's nothing to dump, but just potentially you could remove your systems review or remove such an in-depth systems review. And you can get through a history really quickly. Like, you can be like, okay, I'm going to ask you, like, thanks for telling me about your issue. I'm now going to run through and ask you a series of questions. I'm not expecting a yes or no to any of them. I'm just interested. Do you take any medications? Yes. Which ones? Okay. Do you have any allergies? Have you been abroad recently? Do you smoke? Do you drink alcohol? Do you take drugs? Do you have any conditions that run in your family? Okay, like really, really not hard, can do it in 2 minutes. Okay. Right, these are his bloods. So this was this 75-year-old short of breath person. I'm going to be quiet for a moment while you look through all of those. Okay. So how would you manage this patient? I'm not going to interpret the bloods for you yet. Colonoscopy. Just one colonoscopy. Brutal. Do CBC. I'm guessing that's capillary bile gas. No, I don't know what CBC is. You can type in the chat. I'm not familiar with that acronym, apologies. Investigate anemia, look for cause of anemia, bloods, fit test or colonoscopy. ABG, perfect. Okay, all of these are really good. So really helpfully, whoever put colonoscopy, I agree, but are you going to just shove a camera up the bottom of this man with a hemoglobin of 71? Probably not. You're in GP, so you're not going to do a colonoscopy. So we need to get him into a place where he can be investigated. And if I go back to this, that hemoglobin is low, okay? 71 is low. If he had a heart history under 80, he would need a transfusion, okay? Under 70 without a heart history needs a transfusion, but someone needs to see this gentleman and work out, has it been an acute blood loss or has it been chronic? Is he symptomatic with it? Because if he is, I mean, arguably anyway, he should go to hospital for an assessment. And so yeah, so you need to, so management would be see him first, do the bloods, we'll come on to this. So first of all, hemoglobin is low at 71, white cells are fine, platelets are okay, MCV is low, which you guys picked up, so we'll chat about that in a second, okay? So low MCV, and if you see here, all the rest of it's okay. So we chatted about that. Oh, so those were the options. Oh, I didn't make that into a thing, sorry. So how would you manage him? Safety net and home, start or rely on, consent him for a blood transfusion, refer him for 2-week wait, ask him to attend hospital. So I meant for that to be a question, not a list, as in that's not the order you do things. You would not send this man with a hemoglobin of 71 home. Do not do that. So what you would do is send him to hospital or ask him to go to hospital, because if he's short of breath, we need to work out, or like has any symptoms, we need to work out what's going on. And he said he was short of breath, so he needs an assessment. So we'll chat about it in a second. So anemias, most likely thing to come up in haematology. You want to know, is it microcytic, normocytic or macrocytic? Those are some of the causes. I would really encourage you to know 3 differentials for each one. Okay, I'm not going to go into them because I think it's taught quite well in medical school, but for your OSCEs, know how to identify a microcytic, normocytic or macrocytic. So look at the MCV and know differentials for it. Okay. So how would we manage this guy? We'd do a full exam, we'd do a PR to check that he's not got any rectal bleeding. We'd check his observations, we'd do his news score, we'd do his bloods, and we'd get a fit test. If we were in GP, we'd request one. But really what we would do is we'd make sure he's stable, and if he's not, which arguably he's not, if he's short of breath, he's symptomatic, we'd refer him to hospital for a blood transfusion. If he's not accepting of a blood transfusion, we could give him a Ferinject injection, so it increases iron. We would safety net him on his way to the hospital or send him in an ambulance. Give everyone a leaflet, okay? I don't really care. Like, just be like, oh, would you like a leaflet explaining about this anemia? And then I've put these 2 in italics about supplementing in a 2-week wait for a colonoscopy. because one of the causes of iron deficiency anemia is a lower GI cancer, and the colonoscopy is how you manage that or how you investigate for that. So those that if this case had a hemoglobin of like 100, then you could say, okay, we'd start supplementation, but would refer you for a 2-week wait. Right, so that's anemia. We've chatted about blood transfusions within that. So a really, really great one is how to consent for a blood transfusion. Oh, there's a fly. So you're gonna wash your hands, introduce yourself, put on your PPE and explain what you're gonna do and get permission. Then check what the person knows. So do they know why they need a blood transfusion? Do they know about blood transfusions? Tell them. So then you go into, so you've talked about what they know, tell them why they need it, and then what's going to happen. So the BDA, before, during and after, which we'll come on to in a second. The risks and their benefits, and then what the alternatives are. And this structure is for explaining every single procedure or anything, okay? You just take this and apply it to different ones. So see if you can do consenting for a blood transfusion or explaining for a blood transfusion, explaining for a colonoscopy, a sigmoidoscopy, all of the things, okay? So these are the risks and the benefits. So risk or benefits, let's start with. You're going to get your symptomatic relief. You're going to increase your hemoglobin very quickly. So you're going to put less strain in your organs, and you're going to get better quicker, basically. The risks, wrong person, wrong blood, shouldn't happen, but potentially could. A transfusion reaction, say TACO or TRALI, which is like a transfusion-related acute lung injury, and the other one is like circulatory overload and infections. Everyone's always worried about infection. If I was guessing in OSCE, they'd probably put someone old who's heard about all of the scandals of the hepatitis, etc., and HIV from previous blood transfusions. And then you need to say, lots of, their blood undergoes lots of tests. It's very unlikely, blah, blah, blah. Okay. These are the alternatives. So you can give IV Ferinject and tranexamic acid if they're going to have surgery to stop them bleeding as much. Erythropoietin injections, and you can use cell salvage, but I wouldn't start suggesting that because they're just going to look at you and be like, but just think, is this person a Jehovah's Witness? Do I need to think about this a bit more and talk more about the alternatives and about the risks and benefits of not having one and of having one? Okay, so the risk of not having one, I should have put it here. This is the risk of a transfusion, but the risk of not having a transfusion, death. Okay, they might bleed out. Right, so this is before, during and after a blood transfusion. Before, take 2 group and saves, we check the bags, we check your name against the band, and we ask for your consent. Then during your blood transfusion, you'll be hooked up to the blood through an IV cannula. We'll monitor you every 15 minutes, half an hour, depending on kind of where you are in your transfusion. And if you're unwell, you need to tell us. And you need to alert us to X, Y, Z, okay? After your blood transfusion, we'll continue to monitor you because you can have a delayed reaction, but those are rare and we're not expecting them, okay? So any questions just yet? I'll just check this little box with the chat. Do you start iron before confirming iron deficiency? From a GP perspective, which is what I'm on at the moment, which is where we see a lot of this, yes, you do. So you can start iron, and you can, if you don't know if it's iron deficiency, so there, I purposely didn't give you a ferritin or any iron bloods, but you can start iron before. You can say we can start investigating for an iron deficiency anemia because that's the most likely cause, but within the investigations, we'll also confirm the diagnosis. And if it turns out not to be iron deficient, then we can change management. We can stop the iron tablets. Very few issues with iron tablets apart from bowel changes. Okay. Right. Case 2. Alfred's a 2-year-old child. Nursery have noticed that he's pale and withdrawn. 2 weeks ago, Mum noticed a lump on his neck. He's attending with his mother, take history and perform a relevant examination. Okay. So 2-year-old, pale and withdrawn, got a lump on his neck. What are you going to ask and what are you going to examine? Lymph node, nice, yep. Tiredness, yep. Guess you're going to ask about tiredness. How long has it been? Is it increasing in size? B signs, ask about feeding. Yeah, these are all fab. Head to toe. Yeah, head to toe would be good, but might be difficult to do in an OSCE. Yeah. Okay. So this is kind of, if someone presents with a lump and you don't really know what else to do with it because they've not got any other signs, this is what to do. My big medical tip was the 3 M's. So for my OSCEs, every time I went in for an examination, I'd look around and I'd always go, hello, my name's Kirsty Foster, blah, blah, blah. There are no monitoring aids, mobility devices or medications that I can see around the patient. So always start with the 3 M's for your inspection. Or, you know, if there are, say, there is a mobility device of a wheelchair next to the patient, but there are no monitoring aids or medications. Okay, 3 M's. And then for this, you would look at them, so inspect them. I've applied the look, feel, move. Feel all of the lymph nodes, so cervical, axillary, inguinal, and then move. So you'd want to do an abdominal exam. Just think for a second, why? Because you want to know whether they have any hepatomegaly or splenomegaly. Okay. Lymph nodes, right, I do not want to see you playing the piano, okay? It's not about this. It's about rolling, okay? So using these 3 fingers, so start in your submental, go down to your submaxillary, tonsillar, anterior cervical chain, posterior cervical chain, occipital, postauricular, and then you can check the Virchow's and supraclavicular as well if you want. Okay? Not very difficult. Get a friend and have a feel of their neck. It's okay. Okay, so this child probably has a leukemia, but we're going to talk about why in a second. Leukemias, I think, scare people in that they're quite complex. I used to always forget which one was which, so I've summarised them. Okay, so ignore ALL for a second. We're going to chat about that in a minute. CML, okay, chronic myeloid leukemia. So it's chronic, so it's slow onset. I've put in here the main things to know about it. It's associated with Philadelphia translocation. It's insidious. It has 3 stages, hence this taxi cab, chronic, accelerated, and blast cells, and it's managed with imatinib, which is a tyrosine kinase inhibitor. And that's what this causes, okay? So that this acts on all of this bit. You don't really need to know too much about it. I don't think it's going to come up in OSCEs, but it's useful to understand. CLL, it's all about, so it's the lymphocytes that are affected, the L, this lymphocytic. It's usually over 55s and they get these smudge cells. So you see down where the arrows are pointing, the cells have been smudged because they're quite fragile. And the thing to know about these is they get Richter's transformation. So it transforms into a high-grade lymphoma. 1/3 stay the same, 1/3 get better, and 1/3 get really ill. Okay. And then AML, not really that much to know. If you hear the word aura rods, that's probably AML. You don't need to know much else, okay? So this is my favourite part, so I hope you enjoy this. I made this up for finals, so ALL, so acute lymphoblastic leukemia over there in the top left. So this is everything you need to know, in my personal opinion, about ALL, okay? So if you can remember little Luke lobs balls down, then you'll be able to do ALL, you'll know about it, okay? So little, because the peak incidence is 2 years to 5 years. Luke, because more common in boys. Lobs, so LOBS, that's throws, in just if you're not an English speaker. So lobs, so they get lymphadenopathy, so their lymph nodes are raised, like in this case. Organomegaly, so a large spleen and a large liver. Bone marrow failure, so they're probably going to get some anemia, maybe some shortness of breath, might be pancytopenic, and a sneaky fever, because fever didn't work anywhere, so it's a sneaky one. Balls, because there's blast cells for the B, and the balls because testes are a sanctuary site. So that means that boys are treated for longer. Okay, boys are treated for 3 years in their maintenance and girls are treated for 2 years. So your induction and your maintenance, induction is the same for the chemotherapy, but maintenance is longer in boys. And then down, because it's associated with Down syndrome. Okay, I can go over that again later if you need me to, but personally think it's genius. But maybe that's too far. Okay, so that's all about the leukemias. So now, just as we come to a close, I will finish in a second and we're at time. You're in F1, someone's come in unwell, they've got a background of asthma, eczema and colon cancer. The observations are as shown. So heart rate's 111, blood pressure's 91/53, respirate's 23, temperature's high. I'm like, oh, they look sick and they've got a history of colon cancer. Okay, so I'm not going to ask you what you're going to ask in the interest of time. Instead, I'm going to give you the blood. So just have a second to look at those. Okay, so we've got a low normal hemoglobin, low white blood cells, slightly low platelets, normal MCV, neutrophils, whoa there, 0.4, okay? Do not stop there, all right? You've got your diagnosis. He's septic and he's got low neutrophils. So we know probably neutropenic sepsis. Do not ignore the fact that you've got more blood tests, okay? This is to really home in. You've got to keep looking at all the rest of the bloods. So his urea is pretty high. Oh, that creatinine. And his EGFR is 53. Like, should be over 90. He's all right. Like, he's, not that old. So probably AKI related, right, or a urinary tract infection. Neutropenic sepsis, so the definition is a neutrophil count of under 0.5 and a temperature, or they're unwell. You investigate this like any sepsis. Always, so when they say how you're going to manage it or investigate it, so check their OBS, do a full set of bloods and cultures. Blood cultures are important. BBG to check they're not acidotic, not got a really high lactate, don't need loads of fluids pumped into them. Check an ECG, chest x-ray, urine dip and MSU in this person. So you want to find a source. And then what's sepsis 6? I'm sure you know this, but just humour me and tell me. Oh no, one wants to type it. Or maybe you're actually saying it out loud. So 3 in, 3 out. So let's go. Oh, yep, oxygen antibiotics, perfect. Take blood culture, yep. Urine output, yep. Lactate, yep. And fluids, someone tell me fluids. So yeah, fluids. So given fluids, antibiotics, and oxygen, take out lactate, blood cultures, urine monitoring. Okay. Other key hematological diseases, I'm not going to go through these right now because they're not that exciting and I don't think they'll really come up in OSCEs, but I've written a little summary and highlighted the important things, okay? So a lymphoma is a proliferation of your lymphocytes. The only difference basically between Hodgkin's and non-Hodgkin's are these Reed-Sternberg cells, okay? And Ann Arbor staging I would know about. So basically is the cancer above and below the diaphragm or just above? If it's above and below, bad news. If it's just above, that's fine, or below. Myeloma, again, a little summary of it. Probably not going to come up in your OSCEs, but I just thought it would be helpful because it's quite poorly explained. You'll get the slides, so you'll be able to see these. And there's probably not time, but I was going to give you a chance to vote, but instead I'll ask questions. So do you have any questions about all of that? I'm aware it was a little bit of a gallop through haematology, but hopefully it has explained some of the slightly more complex haematology bits. So we've covered, I should have put a summary slide, but we've covered anemia, we've covered leukemia, and we've covered neutropenic sepsis.